Anticholinergics are the drugs which will act against the action of the acetylcholine. So they will oppose all the actions of acetylcholine. Hence the name anticholinergics, or also known as parasympatholytics. Okay. Now this we have seen in previous other videos, on the video on autonomic nervous system and also in the cholinergics drugs, where we saw that how acetylcholine acts. So there are various types of receptors we discussed. Just quick revision here, because again if we have to understand the action of the anticholinergics, then we should understand how and what is the action of the acetylcholine, right? So acetylcholine acts on the postganglionic neuron of the sympathetic and parasympathetic system. So there is a preganglionic neuron and a postganglionic neuron. On the postganglionic neuron there are acetylcholine receptors present, and these are nicotinic receptors, okay, N receptors, and they are present on both sympathetic and parasympathetic postganglionic neurons. Then we have NM receptors which are present in the neuromuscular junction. So we have nicotinic acetylcholine receptors, that is NN type and NM type. Then other receptors are muscarinic receptors. So here there are muscarinic receptors where M1 receptors are present in stomach, brain. M2 receptors are present in the presynaptic neuron. So suppose this is the neuron which is releasing acetylcholine. M2 receptors are present here itself. Okay, and M2 receptors, when stimulated, say this acetylcholine will act on these M2 receptors. These M2 receptors decrease the secretion of acetylcholine. Okay, decrease secretion of acetylcholine. Then M2 receptors are present on heart, where they cause a decrease in the heart rate and also decrease in the conductivity. Okay, decrease in the heart rate, decrease in conductivity. In stomach, what they do? They are responsible for HCl secretion, okay, and in brain they are responsible for cognition, and also in basal ganglia. Basal ganglia, there is a balance between acetylcholine and dopamine. Okay, acetylcholine and dopamine, this balance has to be maintained, right? Then M3 receptors act on the glands and the various smooth muscles of the body, right? So in eyes there are two smooth muscles, sphincter pupillae, so where it causes the sphincter pupillary constriction leading to constriction of the pupil. Then there is ciliary muscle. Ciliary muscle, it causes accommodation of the lens, okay, increase in curvature of the lens for the near vision. In bronchus, it causes bronchoconstriction. There is also increase in the tracheobronchial secretions, okay. Then GIT, again there is increase in GIT secretion and there is increase in motility. Bladder, again there is increase in motility, so there is a detrusor muscle contraction and relaxation of the sphincter. Glands, as I told you before, that it causes increase in the secretion of all the glands. There is increase in lacrimal secretions, increase in salivary secretions, increase in tracheobronchial secretion, increase in GI secretion, and vessels also this M3 receptor is present, and there in vessels it causes basically release of nitric oxide, okay, and there is no neural supply. Remember that there is no neural supply. Only if acetylcholine or acetylcholine agonist is present in circulation, it can bind to these M3 receptors, which will cause release of nitric oxide and there will be vasodilation, okay, but no neural supply. Fine. So this is fundamental for understanding anticholinergics or parasympatholytics, okay. So with this, let us move on to the classification of anticholinergics. Well, anticholinergics, depending on that where the blockage is occurring, they are classified as muscarinic blockers if they are blocking M1 to M5 receptors. Then there are nicotinic blockers. In nicotinic receptor blockers, we have ganglion blockers if they are blocking NN receptors, and NM receptor blocker, they are known as neuromuscular blockers, okay. So in this video, we will focus ourselves only on muscarinic blockers, right? So what is the classification of these muscarinic blockers? We have natural alkaloids and there are semi-synthetic or synthetic alkaloids. I have clubbed all of them in one, right? Now, in natural alkaloids, we have atropine and hyoscine. Hyoscine is also known as scopolamine. Scopolamine. okay, atropine and hyoscine, and these are non-selective blockers. That means they are going to block all the receptors from M1 to M5, okay. Then in semi-synthetic and synthetic we have tertiary amines and quaternary amines. Simple to remember that these atropine, hyoscine and all the tertiary amines, they can cross blood-brain barrier and also cross the cornea. Tertiary amines can cross. But quaternary amines, they have like this NH4 plus. So this, because of this ion, they cannot cross the blood-brain barrier, and these include glycopyrrolate, ipratropium and tiotropium. So easy to remember, okay. Quaternary amines, what are the ones? Glycopyrrolate, ipratropium, tiotropium. Rest all other are going to cross the blood-brain barrier, okay. Now we will see what is the effect of these anticholinergics on each of the systems one by one. Okay, so that is how we will classify this anticholinergic drugs. Till now in cholinergics we saw that how each drug and what is the effect. Now in this we will see that in CNS what is the effect of anticholinergics, in GIT what is the anticholinergic effect, and what are the drugs which are used and why. Okay. So for the effect on central nervous system, we have two drugs, that is atropine and hyoscine. Okay. Now main difference between these two, you should remember that atropine, low dose, it has no direct effect on CNS. Neither it will cause CNS stimulation nor it will cause CNS depression. However, at high doses, it causes CNS stimulation, while hyoscine in normal doses only, it causes CNS depression. Okay, so atropine, CNS stimulation, in very high doses, CNS stimulation followed by depression. Hyoscine, it causes CNS depression. Okay, so that is the main fundamental difference between these two. Now, atropine is drug of choice for organophosphate poisoning. This we have seen in our video on cholinergics, right? What is organophosphate? Organophosphate is acetylcholinesterase inhibitor, right? Acetylcholinesterase inhibitor means acetylcholinesterase is an enzyme which breaks down acetylcholine into choline and acetate. So if anything is inhibiting acetylcholinesterase, more acetylcholine is going to accumulate and we will get more acetylcholine effects, right? So to counter that, what to give? We will give a anticholinergic. So that is why atropine is given. So atropine, remember, is a drug of choice for OP poisoning and also for early mushroom poisoning, because this early mushroom poisoning occurs due to a mushroom species, inocybe, which has muscarine-like property. This also I have dealt in my video on cholinergics, okay. So that is second thing. But this atropine is contraindicated in poisoning due to other mushroom, Amanita muscaria, because this has opposite effects. Okay, this I will deal in my video on mushroom poisoning separately. But remember that OP poisoning and early mushroom poisoning, drug of choice is atropine, right? Coming to hyoscine, hyoscine also known as scopolamine, I told you it leads to CNS depression. And it is drug of choice for prophylaxis of motion sickness. Prophylaxis. Prophylaxis means it is used to prevent motion sickness. What is motion sickness? Motion sickness is that when we travel in a car or when we are going round, especially in hilly area, what happens? There is a lot of stimulus going via our vestibular apparatus, via the vestibular nerve to the vestibular nuclei. And then from that vestibular nuclei, information goes to vomiting center. Okay, and this leads to vomiting. So that is known as motion sickness. Now this vestibular nuclei has certain receptors, and these receptors are this muscarinic receptors, okay, muscarinic receptors, that is M1 receptors, and there is also histaminic receptors are there, okay. So this muscarinic receptors M1 are blocked by this hyoscine. Right, so that is why hyoscine is drug of choice for prophylaxis of motion sickness. And prophylaxis, when we are talking that it is prevention, that means it should be given at least 30 minutes before start of the travel. If you give after motion sickness has started, then it will not be effective. You have to give 30 minutes prior to the start of the travel, okay. And how it acts? It acts the muscarinic receptors present in the vestibular nuclei. These muscarinic receptors are also present in this vomiting center neuron, so it blocks those also, okay. But because It is blocking these muscarinic receptors present in vestibular nuclei. That is why it is most effective in vomiting caused due to motion sickness, right? Because there is involvement of the vestibular apparatus. Fine. Second thing is this hyoscine is also used as a drug for narco-analysis, what is known as a lie detection test. Okay, so when we give the person this drug for lie detection test, it will cause CNS depression, and you see that cholinergics also have a role in cognition. Okay, so that cognition part is blocked, and that is why in lie detection test person cannot manipulate the person. Whatever is truth is just comes out. So that is truth serum, narco analysis, or lie detection test. Third thing in CNS is Parkinsonism, use in Parkinsonism, right? So in Parkinsonism, as I told you before, that there is a balance between acetylcholine and dopamine. In Parkinsonism, what is the main problem? There is loss of the dopaminergic neurons, and hence dopamine acts less on the receptors. Okay, now either we give dopamine, right, that is L-dopa, that is one treatment of Parkinsonism, or we can decrease acetylcholine. See, it is a balance between acetylcholine and dopamine. So if dopamine decreases, decrease the acetylcholine effect also. So that is one of the physiological basis of treatment in Parkinsonism, and especially this is used in drug-induced Parkinsonism. In fact, anticholinergics are drug of choice for drug-induced Parkinsonism. Why? Because these drugs, for example, the drug used for psychosis, that is the antipsychotic drugs. How they act? They basically block these D2 receptors. Okay, so even if we give L-dopa from outside, D2 receptors are already blocked. That means L-dopa will not be able to act on the D2 receptors. So what to do? Better decrease the other neurotransmitter, that is acetylcholine. So give anticholinergic so that acetylcholine does not has that much effect, right? So what are the drug of choice? Benzhexol, which is also known as trihexphenadione, benztropine, piperidine. Benzhexol, benztropine, piperidine. Okay, so these are the drugs. Okay, so that was all about the CNS. What are the things we studied? Atropine, drug of choice for OP poisoning, drug of choice for early mushroom poisoning. Okay, then hyoscine we saw, drug of choice for prophylaxis of motion sickness, and it is also used for narco analysis or truth serum. Then these anticholinergics are drug of choice for drugs induced Parkinsonism. Fine. Moving on to the next action, that is their action in the eyes. In the eyes, I told you that acetylcholine acts on the muscle sphincter pupillae, causing its contraction, that is constriction of the pupil. So if this action is not there, there will be dilation of the pupil, that is known as mydriasis. On the other hand, ciliary muscle contraction leads to accommodation of the lens. So if ciliary muscle doesn't contract, accommodation of the lens will be lost. Okay, so that is known as cycloplegia, mydriasis and cycloplegia. Okay, so in eye, the drugs anticholinergics which are used are 4: atropine, homatropine, cyclopentolate, and tropicamide. If you see, all these have atropine in their name. Atropine is there, homatropine, right? Atropine, we can say atropine is there, right? So, and cyclopentolate, I remember like it is causing cycloplegia. Okay, so that is cyclopentolate. So 4 drugs: atropine, homatropine, cyclopentolate, and tropicamide, and these are arranged from longest to shortest acting. So what will be their use in eyes? See, tropicamide is the shortest acting. That means its action starts between like 30 to 40 minutes. Okay, and because it is causing mydriasis, that is dilation of the pupil, it is used for refraction error testing in adults because of its quickest and briefest action. It is reversible also. It will very fast. Its action will go. On the other hand, if atropine, if you give, then its action will stay there for 3-4 days. Okay, so instead quickest and briefest acting tropicamide is given for refraction error testing in adults. Other is atropine. Atropine is given because of its long duration of actors in the cases where there is ciliary muscle spasm. Okay, so we want to relax that muscle, and that happens in anterior uveitis. So in anterior uveitis, the anterior part of uvea, that is the ciliary muscle, there spasm occurs. Okay, so that has to be relaxed, and that is why atropine is given, and because of its long duration of action, it is beneficial also. Then it is also used for fundoscopy in children. See, fundoscopy means we have to look at the whole fundus region, okay, in the retina. For that, it is important that there should be proper pupillary dilation, so that we have a look at the entire region of the retina. So it is important that pupil is dilated. However, sometimes if there is dilation and also ciliary muscle relaxation occurs, then it can precipitate increased intraocular pressure in susceptible individuals. Okay, so it cannot be used in elderly because it can precipitate glaucoma in that. So this, you see that this anticholinergics are contraindicated in glaucoma. They should not be used. We saw in cholinergics that pilocarpine and physostigmine, how they were used in glaucoma. So if they are being used in glaucoma, anticholinergics are contraindicated in glaucoma, right? So that was about eye. Moving on to a third one, that is bronchus. Bronchus, what is the action of acetylcholine? It causes bronchoconstriction. So anticholinergics will cause bronchodilation. Then they are also going to decrease the tracheobronchial secretions. So for this, the anticholinergics which are used are ipratropium and tiotropium. Now this, you see, again there is term atropine in them, atropium, okay, tiotropium. So this is atropine, ipratropium and tiotropium. Ipratropium is short acting, tiotropium is long acting. Ipratropium known as short acting muscarinic antagonist, that is SAMA. Tiotropium long acting muscarinic antagonist, that is LAMA, okay. And these are used mainly in COPD. See, they are causing bronchodilation, and in COPD pathophysiology, the main reason for bronchoconstriction is parasympathetic tone. So there is increased parasympathetic tone in this COPD. So that can be relaxed by this ipratropium and tiotropium. On the other hand, asthma, yes, it can be used, but better to use is beta agonist. Better to use is beta agonist, which will cause stimulation of the sympathetic tone, which will cause bronchodilation. Okay, so ipratropium, tiotropium, that is anticholinergics, better used in COPD. And there is one advantage of these drugs compared to other anticholinergics. See, in other anticholinergics, there is one problem that yes, they decrease the tracheobronchial secretions, but they also decrease the mucociliary clearance. So because of this, that whatever secretions are there, they cannot be removed and they get blocked there. And sometimes they can pluck the small bronchioles, and below there will be alveolar collapse. Okay, so it's like this is the alveoli, and here if there is blockage of the secretion, then this alveoli is going to collapse. Not good, right? So this ipratropium and tiotropium do not have this effect. They do not cause this they do not negatively affect this mucociliary clearance. They cause bronchodilation and they decrease the secretion. And how they will be used? They are used by nasal route, right? So they are basically inhalational drugs. Other anticholinergics for bronchus include glycopyrrolate, which is mainly used for pre-anesthetic medication during general anesthesia, and that also decreases the tracheobronchial secretions, right? So you see all these three, glycopyrrolate, ipratropium and tiotropium, are the ones which we classified in quaternary amines. Okay, so they are mainly used for decreasing the tracheobronchial secretion and for bronchodilation. Fourth comes the effect on the heart, right? Heart, what acetylcholine does? It causes a decrease in heart rate, it causes decrease in the conduction. So atropine is used to increase the heart rate and increase the conduction. In fact, it is drug of choice for heart block. Okay, heart block, it is a drug of choice. Now this atropine, when used, it causes initial transient bradycardia and then it causes tachycardia. When it is used for bradycardia, it causes initial transient bradycardia. Further, it increases the bradycardia and then it causes tachycardia. See, I told you before that there are M2 receptors present on the neurons which are releasing the acetylcholine. Now this atropine is a non-selective blocker, so it blocks this M2 receptors as well, and because of this initially there is increase in the release of the acetylcholine. So it causes bradycardia, but later on there is tachycardia because atropine blocks the M2 receptors present on the heart also, right? So in the heart, atropine is drug of choice for bradycardia and for heart block. Fifth, the effect on GIT. So for the effect on GIT, we have M1 blockers and M3 blockers, right? M1 blocker include perenzaprine and tenenzapine that are used for decreasing acid secretion, but these drugs mostly have been replaced by the drugs which include H2 blockers, okay? Histamine receptor blockers and the proton pump inhibitors which are used to decrease acid secretion, okay? But in some countries still this perenzaprine and telenzapine are used to decrease acid secretion. Then we have M3 blockers. You know that acetylcholine increases GI motility. So these M3 blockers will be used for decreasing GI motility, right? So they are used as antispasmodic. So this dicyclomine is a drug which is used as antispasmodic, and buscopan. Dicyclomine and buscopan used as antispasmodic and also for motion sickness and morning sickness. And since they decrease GI motility, they are used for irritable bowel syndrome, diarrhea type. Okay, there are two types, constipation type and diarrhea type. So constipation type, already there is decrease in motility. In diarrhea type, there is increased motility. So to decrease the motility, we can use this anticholinergics. Fine. Why will be they used in motion sickness and morning sickness? I told you that these muscarinic receptors are present on the vomiting center as well as on the vestibular nuclei, right? So if they block these receptors, they can be used for motion sickness and morning sickness, right? Then finally in the drugs, we have the drugs which act on urinary bladder. These are vesicoselective drugs, that is mainly they are acting as M3 blocker, but remember they are not like complete, only very selective M3 blocker. They have some effect on other muscarine receptors as well. However, relatively they are much better M3 blockers. So these include a list of drugs is there: flavoxate, oxybutynin, tolterodine, fesoterodine, solphenacin, darifenacin. Okay, so in this, oxybutynin is the shortest acting and solphenacin is the longest acting. Okay, and when should they be used? See, acetylcholine is increasing the contraction of the detrusor muscle. So these anticholinergics will be used where we want decreased contraction. So they are used in urinary incontinence caused by overactive bladder. So we want the bladder to contract less. So there will be detrusor muscle relaxation, right? But remember that they will be contraindicated in benign prostatic hyperplasia. Why? See, in benign prostatic hyperplasia, already the urination is affected. There is blockage in the pathway. So now if the detrusor muscle is relaxed, here there is blockage in the pathway. If you relax the detrusor muscle further, then there will be urinary retention. No urine will flow out. Okay. So in these cases, there should be contraction of the bladder to pass out the urine. Okay. So contraindicated in benign prostatic hyperplasia. So that was all about the anticholinergic drugs. Finally, coming to one very important part, that is atropine poisoning. Atropine poisoning or belladonna poisoning or such poisoning can also occur due to dhatura seeds. Okay. What happens that there will be too much blockage of action of acetylcholine, right? And so the effects which we will see will be totally opposite to the effects of acetylcholine, right? So we have dry mouth, dry eyes. You see, acetylcholine causes increase in the secretion. So we have here very less secretion. So dry mouth, dry eyes. Blurred vision, pupillary dilation. So imagine the effect on eyes, right? Pupil constriction is the effect of acetylcholine. Here we are having pupil dilation. Increased heart rate. Acetylcholine causes bradycardia. Here it is increased heart rate. Urinary retention due to detrusor muscle relaxation. Constipation because GI muscle contraction, relaxation, right? Hyperthermia, because there will not be any sweating, so that will lead to hyperthermia, dry, hot skin. Then cognition will be affected. Acetylcholine is important for cognition, so it will lead to confusion, delirium, restlessness, and ultimately too much effect, it will lead to coma. Okay, so that is atropine poisoning features. And how to treat it? Treatment is, the drug of choice is physostigmine. Physostigmine is a cholinergic. So here atropine is an anticholinergic. So for treatment we will give a cholinergic, and that is physostigmine. Okay, physostigmine, I told you on the video on cholinergics that physo is slippery, right? So it is going to cross the lipid membrane, right? So it can enter the central nervous system as well. So drug of choice for atropine poisoning, belladonna poisoning, or the poisoning due to the datura seeds is physostigmine. So that was all about the anticholinergic drugs. Thanks for watching the video. If you liked it, do press the like button, share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.